Good evening, everyone, and welcome to the Nation's Weekly webinar. So today our topic is controversies around ruptured aneurysm. So it's going to be a very interesting topic on vascular neurosurgery. So I think we are already in time. So without delay, let's start the presentation. So the first speaker is Dr. Binod Raj Bhandari from Tirubhavan University Teaching Hospital. His topic is dilemma in preoperative management of acute subarachnoid hemorrhage. So Dr. Binod Raj Bhandari, please go ahead with your slides.
Thank you, Dr. Manoj. First of all, I'd like to thank the organizing team of this amazing webinar series all the team for providing this opportunity and creating a platform where we can upgrade our knowledge. SCS, subarachnoid hemorrhage, is one of the diseases with high mortality and morbidity, especially aneurysmal one. So there are various aspects of this aneurysmal SAS, but today I am going to focus on the perioperative management of this SAS. So it is one of the significant cause of morbidity and mortality throughout the world. The incidence of the SAS, it varies among the different populations. The WHO study found a 10-fold variation in the age-adjusted incidence in countries in Europe and Asia, from 2 cases per 100,000 population in China to the 25 cases per 100,000 in Finland. But there is no actual data of the Nepal for the incidence of SAs till now. And extrapolating this data, considering the 10 per cases 100,000, we might have 10,000 cases of the SAs per year. So this is a medical emergency, but it is one of the medical emergency that is frequently misdiagnosed. So we should have a high level of suspicion for aneurysmal SAs in patients with acute onset of severe headache. And head CT should be done, even those for the patient with alert and neurologically intact dishes at the time of initial presentation. The additional clues to be diagnosis of the SAs, such as periretinal hemorrhages, neck pain, or meningitis, may or may not be present. So to minimize this misdiagnosis, there is a rule known as the Ottawa SAS rule. This rule is for the alert patients for more than 15 years old with the new and severe non-traumatic headache reaching maximum intensity within 1 hour. And the patients require, according to this rule, the patients require investigation if they have one or more of the findings present up below, such as age more than 40 years old, symptoms of neck pain or stiffness, weakness, loss of consciousness, onset during exertion, thunderclap headache, or the limited neck flexion on the examination. This rule has a sensitivity of 100%, but the specificity is only 15%. So only 14 to 15% of the patients they have eliminated the need for the evaluation. So high number of patients have been evaluated with the CT or something other investigations. So the standard diagnostic approach for this SAS is usually the initial test is non-contrast CT8. The sensitivity of this CT is usually 100% in the first hours, which decreases to around 58% at day 5. So if there is a high suspicion of SAS despite a normal head CT, lumbar puncture is the mandatory. But there are also alternative approaches. As CT angiogram has become more available, some neurosurgeons, some neurophysicians have advocated the use of CT angio after a negative HCT for the diagnosis of SAS. Some drawbacks of this CT angio method is that there might be an increased finding of the incidental aneurysm around up to the 3% in the populations. And the utility of MRI is also increasing nowadays for the diagnosis of the SAS, especially in the subacute cases. The flare in combination with the susceptibility weighted image has a very good sensitivity for the diagnosis of SAS. Still, the guideline, the AHA guideline, which is published in 2012, they recommend non-contrast CT8, and if non-diagnostic, this should be followed by the lumbar puncture, which we also follow in our institute. So there are few reasons, the few headings which causes the misdiagnosis or the delayed diagnosis, such as failure to appreciate the spectrum of clinical presentation, failure to obtain a head CT scan or to understand its limitation in diagnosing SAS. This is the most common cause of misdiagnosis of the SAS. It up to the 73% of the cases of misdiagnosis is due to the failure to obtain a head CT in a suspected patients. The failure, another reason is failure to perform a lumbar puncture or correctly interpret the results of the lumbar puncture. With the frequent use of the CT and with the advancement of the CT and other investigation, the misdiagnosis is decreasing. And there is a research which showed that the patient who has been misdiagnosed or the delayed diagnosed, there is increase in mortality, almost up to fourfold at 12 months, and increased morbidity among the even survivors also. So it is very important to diagnose a subarachnoid hemorrhage. So after once the diagnosis of SAS has been made, the etiology of the hemorrhage must be determined in graphic studies. There are various studies available, such as CT angiogram, digital subtraction angiogram, and the MR angiogram. Some of the institute prefer DSA initially because it has the best resolution for the detection of aneurysm and even can facilitate endovascular treatment as a part of the same procedure. However, many centers also use non-invasive imaging such as CTA or the magnetic resonance angiography as the initial study, reserving the DSA for the cases when non-invasive imaging does not identify the cause of the SAS. The major advantage of CTA over DSA is that its speed and the ease of the use, and it is also non-invasive and can be easily useful in the acute condition. So the role of the MRI is increasing, but it is limited due to its low feasibility during the acute phases of bleeding. But the sensitivity of the detection is being good for the both MRI techniques, that time of flight and the contrast enhanced MRI, with slightly better for the contrast enhanced MRI. So what is the recommendation for the patients with negative angiography with the positive SAS? So the no cause is found in around up to the 14 to 22% of the patients. So in these cases, patients, we repeat the angiogram in 4 to 14 days. Usually at the second time, the recommended follow-up test in setting is usually DSA. And up to the 24% aneurysms are seen on the repeat angiography. And this increases up to 49% if perimesencephalic and the normal CT are excluded. So if again the second angio is negative, but there is a strong suspicion of aneurysm, the third angiogram is usually performed at the period of 2 to 3 months. And if the second is this third angiogram is also negative, some perform brain and spine MRI to rule out the vascular malformations. The degree of neurological impairment and the extent of subarachnoid bleeding at the time of admission are the most important predictors of the neurological complications and outcome. So therefore, it is imperative to grade the severity of SAS as soon as feasible after presentation and stabilization of the patient with SAS. So a number of grading systems have been proposed to standardize the clinical classification of patients. There are numerous, such as Huntington's, Tough-Lebanese, Fisher, modified Fisher, which is known as also Klassen, Ogilvy and Carter, PASH, and Vasograde. These are some of the grades. This is the Ogilvy and Carter grading system. It helps to predict the outcome for the surgical management of intracranial aneurysms. It scores from 0 to 5. This is another grade which is recently proposed in 2015. This is the Vasograde. This was developed to predict the risks of delayed cerebral ischemia following SAS. And it combines the WFN scale and the modified Fisher scale at the time of admission. So they divide the aneurysms into 3 regions: green, yellow, and the red. These are some of the general measures which we took during the admission of the SAS. So all we follow this, so I'm not going into the detail of this. So moving on to the complication, the aneurysm rebleeding is associated with a very high mortality and poor prognosis, and the risk of rebleeding is maximal in the initial first 2 to 12 hours, with reported rates of occurrence between around 4 to 13.6% in the first 24 hours. And the 1/3 of rebleed which usually occurs within 3 hours, and half of the rebleed it occurs within 6 hours. And this early bleeding is associated with very worse outcome and then later bleeding. So urgent evaluation and treatment of the patients with suspected aneurysmal SAS is recommended. So this is the guideline from the AHA 2012. We can see the clipping or coiling of aneurysm repair with surgical clipping or endovascular coiling. It is the only effective treatment to prevent this rebleeding, this occurrence, and should be performed as early as possible and should be performed preferably within the 24 hours. And the complete obliteration of the aneurysm is recommended whenever possible. So these are the medical measures which are taken if there is some delay in the um, treatment, such as clipping or coiling. So there are two medical measures which can decrease the incidence of the rebleeding, such as one is the control of blood pressure. The optimal blood pressure is less than 160 millimeter of mercury in the patients which are not clipped. And another is the short-term therapy with the tranexamic acid or the aminocapric acid has shown to reduce the rate of rebleeding. So the blood pressure, there is no optimal level of the blood pressure defined till now. One of the one is the aim systolic blood pressure less than 160 millimeter of mercury, systolic blood pressure, with the use of antihypertensives such as labetalol, nicardipine, clebitibine, or enalapril. Usually, vasodilators are avoided because it can increase the cerebral edema. To prevent the early rebleeding, short-term therapy with tranexamic acid or the aminocapric acid is reasonable whenever there is a delay in the surgical clipping or coiling of the aneurysm, and if there is patient and no contraindication for the antifibrinolytics. It has side effects such as increased risk of DVT, but it is still not yet approved by the US FDA, though it has been proposed by the AHA guideline. It reduced the rebleed, but it has shown that it did not reduce the poor outcome of the patient. It has increased. It has also shown that use of the antifibrinolytic is associated with the increased risk of cerebral ischemia. So another complication that frequently it is very difficult to manage for all of the neurosurgeons. It's cerebral vasospasm and delayed cerebral ischemia. It is one of the major cause of death and disability in patients with aneurysmal SCS, and usually occurs 4 to 14 days post rupture, and usually resolves after 21 days. The angiographic vasospasm, it is seen in many patients, in the 30 to 70%, but the clinical vasospasm, it is seen in only 20 to 30%. And both the diagnosis and the management of this vasospasm and delayed cerebral ischemia is complex in the patients. So there are three strategies and tools for the diagnosis of the vasospasm and delayed cerebral ischemia in SCS. They can be divided into clinical, radiographic, and physiological. So clinically, monitoring of this vasospasm consists of repeated neurological assessments to identify the new deficits that are attributable to the ischemia or infarctions, and many other cause of the deterioration should be ruled out. So we have various tools, such as we can use the transcranial Doppler velocities, where the increase in the velocity of the large artery more than 200 centimeters per second can give us the clue of the vasospasm. Another is pathological reduction in the cerebral blood flow by CT scanning, xenon, thermal spirometry, detection of the cerebral ischemia by AWI, near infrared spectroscopy, microdialysis, direct probe cerebral oximetry, jugular venous oxygen saturation, or the vascular imaging by the catheter-based angiography and CT angiography, which can show the constriction of the vessels. So this is one of the guidelines that transcranial technology is reasonable to monitor for the development of the arterial vasospasm, which we also use in our post-operative period to frequently diagnose the vasospasm. But till now, there is no studies that have been examined for the effectiveness of intervention based on these monitoring tools in preventing or reversing delayed cerebral ischemia. So management of the vasospasm, it consists of avoiding the hypovolemia and euvolemia. So hemodynamic augmentation therapy, it is the first line of therapy in the treatment of the vasospasm. Previously, triple S therapy, which is hypervolemia with hemodilation and the hypertension, used to be followed, but this is associated with frequent complication of pulmonary edema or the cerebral edema. So now the preferred method of treatment of vasospasm is hemodynamic augmentation therapy. So to first line of therapy is used to raise the MAP. We can use the vasopressors such as phenylephrine, norepinephrine, dopamine, and we should maintain the euvolemia using crystalloid or the colloid solution. And during this AD therapy, we should monitor the patient for development of the pulmonary or the cerebral edema and the volume overload. So these are some of the recommendations from the AHA guidelines that admission of the large volumes of hypotonic fluids and the intravascular volume contraction is not recommended after aneurysmal SAS. And the monitoring volume status in certain patients with recent aneurysmal SAS by some combination of CBP, pulmonary wedge pressure, and food balance is reasonable, as is treatment of the volume contraction with crystalloid or the colloid fluids. And the prophylactic hypervolemia or the balloon angioplasty before the development of spasm is not recommended. So another treatment for the vasospasm or the delayed cerebral ischemia is the endovascular intervention. These are usually given to the patients that have not responding to the AD, and those with a certain focal neural deficit and the focal lesions on angiography referable to their symptoms. So balloon angioplasty is usually used for the accessible and the large facial lesions, and the vasodilator infusion for more distal vessels. So different agents can be used, such as calcium channel blockers, verapamil, nicardipine, and papaverine, milrinone. These all can be used, but their duration of benefit is short comparing to the balloon angioplasty. So another agent we frequently use to prevent the vasospasm is nimotipine. It is a widely used calcium channel antagonist. It is usually used orally or NG, and it should be usually avoided using the IV due to its complications. The mechanism of improvement is usually unknown, and it usually improves neurological outcome by preventing processes other than the large vessel narrowing. But recent research has shown that it improves outcomes, but not cerebral vasospasm. And it is usually administered to all the patients with aneurysmal SAS, and it is a class 1 level of evidence is A. And the value of other calcium antagonists, whether administered orally or intravenously, still remains uncertain. So these are some of the other drugs that are studied for the improvement of the vasospasm in the aneurysm, such as endothelin 1 antagonists, such as clazosentan. There is a few trials conducted, CONSCIOUS 1 and CONSCIOUS 2. CONSCIOUS 1 showed some benefit with the clazosentan, but the CONSCIOUS 2 showed no benefit. Statins saw initially beneficial effect, but later also it showed no benefit. Another is the magnesium sulfate. So these are some of the few trials. This is a STAS trial, which used for the simvastatin in aneurysmal SAS. It is the multi-center randomized phase 3 trial, and they concluded that they did not detect any benefit in the use of simvastatin for the long-term or short-term outcome in patients with SAS. And this is the another trial. It is the MAS2 trial for the magnesium for the aneurysmal SAS, and it also showed that intravenous magnesium sulfate does not improve the clinical outcome after aneurysmal SAS. Therefore, routine administration of magnesium cannot be recommended. See, besides drug therapy, there are different alternative methods that have been tried for the treatment and the prevention of the vasospasm. It consists of irrigation of cisterns and fibrinolysis of the cistern, lumbar drain, intra-aortic balloon counterpulsation, and the intrathecal nicardipine. So this is the study which shows the use of intrathecal fibrinolysis for the aneurysmal subarachnoid hemorrhage for evidence from the RCT and cohort studies. And they concluded that the intracisternal fibrinolysis has beneficial effect on the clinical outcome of patient with aneurysmal SAS. This is another study where they performed the systemic review of the lumbar drainage and delayed cerebral ischemia in aneurysmal SAS. They also found that lumbar drainage in SAS appears to be safe and associated with the reduced rate of symptomatic vasospasm and improved clinical outcomes in patients in glute clinical grade with thick clot burden. But the quality of the most available study is weak. So optimal duration and rate of serious diversion remains uncertain. So this is the another study which used the use of intra-aortic pulse counterpulses in patient with symptomatic vasospasm following SAS and neurogenic state cardiomyopathy. So the use of intra-aortic balloon pump may be beneficial as an adjunctive therapy in SAS patients with concomitant symptomatic vasospasm and neurogenic state cardiomyopathy. This is the another study which reviewed the use of intrathecal nicardipine for the treatment of cerebral vasospasm in aneurysmal SAS. They also concluded that the intrathecal nicardipine appears efficacious and safe. After the vasospasm, the another complication we worry about worry in the patients with aneurysmal SAS is hydrocephalus. The acute hydrocephalus develops in around 15 to 87% of the patients, and the immediate CSF diversions with an EBD or lumbar drainage is indicated for the patients who have a deteriorating level of consciousness and the evidence of ICP or the hydrocephalus. But the controversy there is present regarding the preferred mode of CSF drainage through an EBD, either intermittent CSF drainage with rapid EBD win versus continuous CSF drainage with gradual EBD winning approach. There is also controversy regarding which of the patients needs the develops the shunt-dependent hydrocephalus and who needs permanent BP shunt. So Jabarili and colleagues develop a score known as CHASE score. This is the chronic hydrocephalus ensuing from SAS score. They develop the parameters based on the Huntington's as grade 4, grade more than 4, location of posterior circulation aneurysm, requiring acute post hydrocephalus requiring CSF diversion, intraventricular hemorrhage, and the early cerebral infarction on CT scan. And the most of the score they have given weight to the hydrocephalus requiring CSF diversion. Based on this, the patient can be stratified into the high risk, moderate risk, and the low risk, and this gives the probability of patient needing the PP shunt for the chronic hydrocephalus. There is also another score known as STAS score. It is also a scale from 0 to 4 and includes parameters from the existing scale: Barrow Neurological Institute score, Huntington's, and acute hydrocephalus. So these are some of the recommendations for the hydrocephalus from the 2012 AHA guideline. So they said that the symptomatic hydrocephalus should be managed by CSF diversion. The chronic symptomatic hydrocephalus should be treated with permanent CSF diversion, and the winning EBD over more than 24 hours does not appear to be effective in reducing the need for ventricle shunting, and the routine administration of the lamina terminalis and the cisternal irrigation is not useful. This is a study from 2009 which showed that there is no significant association between the lamina terminalis fenestration and the reduced incidence of the shunt-dependent hydrocephalus. And this is another study which showed that the laminar terminalis fenestration during anterior circulation aneurysm clipping reduces the incidence of the shunt-dependent hydrocephalus. So still the controversy regarding this laminar terminalis fenestration in prevention of the chronic hydrocephalus. So another topic, still controversial topic to be managed, the dilemma in the management is the management of seizure post clipping of the aneurysm of the SAS. So overall incidence of the seizure in the patient with SAS is around 6 to 18%. Delayed seizure occurs in 3 to 7%. These are some of the risk factors: the aneurysm in the MCA, thick clot, hematoma, rebleeding, infarction, poor grade. So the management of seizure is dilemmatous or controversial. We have to be considered between the benefits of drugs, between the risks of the drugs. One of the studies showed that the prophylactic use of phenytoin was independently associated with the worst cognitive outcome at 3 months. And they also increases the incidence of the vasospasm, delayed cerebral ischemia, and the fever. So we know that the routine use of AED is associated with the worst functional and cognitive outcome. So current practice guideline, they used to discourage the routine AED prophylaxis and recommend that prophylaxis reserved for the at-risk patient only. So they developed a score known as Safari score, which includes of the age more than 60 years, onset seizure, hydrocephalus, and the location. And they categorize the patient into 3 groups: low risk, moderate risk, and high risk. And depending upon the patient's category, whether it is low risk, moderate risk, or high risk, we tend to use the antiepileptic. So in our practice, we used to give the antiepileptic only in the patients with the moderate risk or the high risk. These are the guidelines from the AHA. There's the use of prophylactic antibiotic may be considered in the immediate post-op period, but the long-term use of AED for the patients with known only in the patients with the known risk factors, such as patients with the aneurysm in the MCA, thick clot, previous multiple seizures, then. And the long-term use of AED in the other patient is not recommended. So these are another complications we should handle during the management of the SAS patients, such as hyponatremia, fever, hyperglycemia, DBT, and cardiac arrhythmias. So hyponatremia, it occurs in around 10 to 30% of the patients, and usually to the cerebral starvation, or sometimes to the SIADS. And usually we have to avoid the fluid restriction for the treatment of SIADS in the case of the aneurysm, because it can worsen the patient's passive spasm. And it is an independent risk for outcome. So 3% NaCl can be used sometimes for the patient in the high grade SAS by improving, it is effective in the patients with high grade aneurysmal SAS by improving regional cerebral blood flow, brain tissue oxygen, and the pH. Fever, it is one of the most common medical complications in aneurysmal SAS. The cause can be many: infection, drugs, central cause, and usually fever associated with the SAS can lead to the worst cognitive outcome. So if you read control, the fever should be done. And the aggressive control of fever to a target of normothermia by the use of standard advanced temperature modeling system is reasonable in the acute phase of SAS. There is also a strong association between the blood glucose level and the poor outcome. And mechanism is usually unclear, but we should effectively control the glucose level to decrease the risk of poor outcome. So another parameter that can decrease the outcome or that can lead to the poor outcome is the anemia, and it is common after SAS and may compromise the brain oxygen delivery. So transfusion of RBC results in a significant rise in cerebral oxygen delivery, and one of the studies showed that the higher hemoglobin values improve outcomes, especially in the patients who are at high risk of passive spasm. But still, the goal of hemoglobin level for transfusion is not yet defined. Some prefer transfusing and maintaining the target of about 8 to 10, and some prefers the target level of hemoglobin higher than 10. So some studies also showed that the transfusion of red cell leads to the worst outcome. So there is still, we are not clear on how much hemoglobin the patients are, or up to how much level we have to optimize the patient during the management of the SAS. So another complication we have to worry about is DBT and PA. Incidence is high in the SAS patient. Usually risk factor is smoking, race, poor maintenance grade, longer hospital stay, and the longer stay in the ICU. So early identification and the targeted treatment are recommended in the management of the DBT, but the further research is needed to identify the ideal screening paradigms. So another frequently occurring abnormalities are the changes in the without a cardiac complexion, but only the ECG abnormalities. We frequently encounter the ECG abnormalities such as prolonged QT interval, cardiac arrhythmias, AFR flutter, myocardial damage, neurogenic pulmonary. These are due to the imbalance between the autonomic cardiovascular control and increasing level of the circulating and the local myocardial tissue catecholamines. So incidence around 4.7 to 50%. These are the independent predictor of the death and disability. Risk factors are the older age, arrhythmia, severe neurological deficit, and so we have to closely monitor the patient for the cardiac abnormalities with an abnormal ECG and admission. This can be either only the ECG admission or maybe due to the heart damage. So it should prompt aggressive measures to treat MI, maintain a normal cardiac rhythm, and minimize the presence of autonomic stress. So to conclude my presentation, the management of aneurysmal SA is a complex undertaking. It is best managed by the team approach. There is no I in the SAS management. So the current state of knowledge of this fast evolving field is still uncertain in many critical areas. And clinicians should use the available literature to provide early, aggressive, and expert care for the individual patient using available resources to improve the outcome. So this is our protocol we follow in our institute for the management of the SAS. So must be similar to the everywhere where they follow. So thank you.
Thank you, Dr. Binod, for a very comprehensive medical management of the aneurysmal subarachnoid hemorrhage. Just goes to show how little we know about this surgical this diagnosis, aneurysmal subarachnoid hemorrhage. No clinical data. So let's move on to the next presentation by Dr. Gopal Senai. This is another very exciting part of the aneurysm presentation. Coil or clip, are we still confused? Gopal, over to you.
Hello, can you see the screen, sir?
Slide is seen, but your voice is very feeble.
Now, sir?
Yes, better. Yes, Gopal.
Is it coming as a full screen?
Not yet.
So what do I do to make it a full screen?
Bottom row ma हुनुपर्छ. Yeah, समय fine.
Yeah, I got it.
Okay.
Thank you, Professor Mohan, for the invitation. Dr. Binod has extensively talked about the various management protocols of subarachnoid hemorrhage, and I am just going to touch on only one aspect, that is to prevent rebleeding. We should not be confused that just preventing rebleeding is not the only treatment of aneurysmal subarachnoid hemorrhage. It is only a part of aneurysmal subarachnoid hemorrhage. So I'd like to start from that. So to claim NMC CPT points, Dr. Amit had asked me to put this slide. So all of you, please log in to Zoom and then do whatever is mentioned here. So this is a slide which I'd love to present regarding coiling versus clipping. So sometimes it's, if you see in an angle, you might think that the top one is winning, but the lower one was the winner. He won the match in this wrestling competition. So coiling and clipping also, they have initially it was clipping which was done, and then coiling came, and again clipping is again trying to take over. So the disclosure conflict of interest is, I am not sponsored by any coil manufacturer or clip manufacturer or a neurosurgical or a radiological society. The only interest of presentation is to improve patient outcome. So as I already mentioned, the management of subarachnoid hemorrhage has so many aspects, and preventing rebleeding is the only thing which coiling or clipping does. Fighting between coiling and clipping, we should not forget that there are other aspects which need more than equal importance. Clipping has a very long history. It started early in 1933 by wrapping of a ruptured aneurysm, and the first obliterative clipping by Dandy in 1938. And after that, slowly there are advances with the inclusion of microscope by Professor Yasargil. And there are different types of different clip reconstruction techniques and bypass procedures. The microscopes and various types of microscopes like Kinevo, which are there now, ICG, intra-op Doppler, and various trainings for proper microsurgical clipping of aneurysms. Similarly, going to the coiling, it started in 1927 after angiography was done by Igaz Moniz, then balloon occlusion by Servenenko, and Guglielmo in 1990 came with a GDC coiling. So this was the paper in Journal of Neurosurgery, electrothrombosis of sacral aneurysms via endovascular approach, preliminary experience. After that, there are different types of advances in coiling, like stent-assisted coiling, different pipeline devices, pulse riders, and the properties of the coils have changed. And as recent as 16 May 2019, there was FDA approval for Atlas stent system. So coiling, after it started in 1990, it has, in the last 30 years, it has advanced rapidly and for the benefit of the patients. So why did coiling came as an option? Because clipping was already there for so long. It came as an option because it seemed minimally invasive. It was a newer and exciting technology. There were possibility of improved outcomes. And it was readily accepted by the treating specialists also and the patients as well. And the coiling has rapidly evolved. The other reason probably is because extensive market-driven global publicity as well. Because there are different types of coils and different types of catheters coming in, and various companies, marketing companies are taking benefit out of it, as well as the patients definitely. So what are the advantages of clipping? It's a time tested, has a better occlusion, less recurrence. The hematoma, if present, can be tackled together. Management of hydrocephalus is relatively better with clipping, and follow-up is also easier. But the disadvantages are its invasiveness, the injuries to the various perforators, and the retraction injuries to the brain. However, nowadays the concept of retractor-less surgery has evolved and is rapidly gaining importance. Multiple aneurysms in bilateral circulation cannot be dealt in the same setting, and higher risk of vascular. Some papers have mentioned there is higher risk of vascular spasm in clipping because we manipulate the subarachnoid space. The coiling, it seems less invasive. Multiple bilateral aneurysms can be treated. If a vasospasm is there, then it can be treated by endovascular measures, and it's a rapidly evolving technology. However, the disadvantages are the cost. The cost of the treatment, if we consider in Nepal, it's higher, coiling is higher. The long-term results, like the rebleeding, the results of incomplete packing, associated hematoma cannot be dealt with by coiling. Wide neck aneurysms are relatively difficult. However, the technology, because of technological advancement, many wide neck aneurysms have now been able to be coiled. If there is a clot in the aneurysm, the chances of the clot causing embolism is high. The distal fusiform aneurysms, they are difficult. Distal and fusiform aneurysms are difficult to be dealt with, and hydrocephalus management is also difficult. So whether to go for coiling or whether to go for clipping, which one is superior? So whenever we see a patient with subarachnoid hemorrhage, this should come to mind, whether this patient should go to coil or this should go to clip. Not that I am an expert in clipping, so I'll be able to clip every aneurysm, or I am an endovascular surgeon, so I'll coil whatever I have. Like if you are a fan of football, then there is always a debate between who is better, greatest of all times, Messi or Ronaldo. So to address this problem, which one is better? So this can be addressed. One of the methods of addressing is by doing statistical analysis, doing randomized trials. So there were different trials which were done. This was one by the Dr. Juha's team from Finland and published in 2000, which shows the 1-year clinical and neurosurgical outcomes were comparable. Then came the ISAT. ISAT was a very big trial, multi-center trial done in Australia, Canada, and UK, in which there was a clinical equipoise. The patients who were deemed to be suitable by both for both endovascular and neurosurgical clipping were randomized. And the primary objective was reduction in death or dependency at 1 year by coiling. And a self-reporting questionnaire was used to measure the outcome by looking at the MRS. It published in 2002 in Lancet. So the result at 1 year, 3 to 6, is death or dependent, 23.7% in the endovascular and 30.6% in the neurosurgical group. So there was more than 6.9% difference. So whenever the results came, everyone was like, whoa, better technology, better results. And what we should not forget is, it's not the only upper one which we are considering. We should also consider the repeat procedures which are more in the coiling group, and post-procedural rebleeding was more in the coiling group. So death and dependency is not the only factor. We should also consider whether the completeness of the packing and the post-procedural subarachnoid hemorrhage, these should also be taken into consideration. So when this study became published, in UK, the clipping reduced by 20% and coiling increased by 33%. In US, clipping reduced by 48%, coiling increased by 40%. So many people started to look at the study, whether this study was really as good as it has been said. So what are the critical points? The critical points are around 9,600 patients were screened and only 2,143 were enrolled. So selection bias, there was a big selection bias. The 88% of patients were febrile grade, 95% anterior circulation, 90% of small aneurysms, less than 70% of the 70-year age was only randomized, and overall hospital mortality was 6% only, whereas in similar centers in the US, it was as high as 26%. The modified ranking scale was used as self-reported modified ranking scale. And this was one of the things which they considered, because if we see the modified ranking scale, 2 and 3, there might not be much difference. And if someone is self-reporting it, then 2 and 3, there might be some difference in 2 and 3. So if you see independently each ranking scale, then there might not be many differences. So, but if you see dependent and death, then only the statistical significance was seen. The expertise of the surgeon. For endovascular, they said that you should have at least coiled 30 aneurysms. The expertise of the surgeon was not explained. And it was surprising that when you look into the data, around 30 patients, around 3% of the patients who were sent for clipping actually were not able to be clipped. That means, was there any problem with the expertise of the surgeon? Because most of the patients, anterior circulation less than 10 mm aneurysms, not being able to clip when operating, there might be a big bias there. And the other thing is, there was a delay for randomization to repair in the surgical arm. The surgical arm, after you have randomized, it took around 18 hours for the patients to be clipped. And in the meantime, many patients re-ruptured and had bad outcome. So these were also included in the surgical arm. So that might be the reasons. And I said they followed up for patients in the UK, because it was a multi-center. The patients in UK were followed for 10 years. And the results were 83% coiling patients were alive and 79% clipping patients were alive with the odds ratio of 1.35. However, what they have mentioned is the risk of death and rebleeding from the treated aneurysms was very small. So we should not forget about the rebleeding and incomplete coiling, retreatment. These are the two things we should consider. So the cumulative percentage of annual number of deaths in neurosurgery was high. However, the cumulative percentage of rebleeding was high in endovascular. And if you see the cumulative risk of rebleed in endovascular, as we already know, the cumulative risk of rebleeding and incomplete occlusion is more in endovascular. And what this is the data what they showed: 83%, 79% with the odds ratio of 1.34. However, in the endovascular coiling, rebleeding from the target aneurysms are more as compared to the neurosurgical clipping. So this was the, after this data which was published by the UK team, UK, Canada, and Australia, then there was a trial which was conceived from Phoenix, Arizona, in the Barrett Neurological Institute, which was a single center. So we should not forget whenever we compare these trials, this BRIAT was a single center trial, whereas the ISAT was a multi-center randomized trial. The important thing is, this was an intent to treat all inclusive trial. So what they did was, whenever you have a patient with subarachnoid hemorrhage, you immediately trial them, randomize them either to coiling arm or the clipping arm. And on doing so, many patients with angionegative SAs were also included, which were later, they were excluded from the trial later on. And many patients, because you don't know the morphology of the aneurysm, and then you have already sent the patient for randomization. So what happened is 238 were for clipping and 233 were coiling. However, a large number of patients first assigned to embolization crossover to aneurysm clipping, and this is a very important thing we should understand. Patients who were assigned to embolization, they were sent to clipping, because this is a single center study and done by a few of the best neurovascular surgeons all over the world, Robert Spezler. So those who were assigned to embolization also went to clipping. This you have to remember. But you see, in 1 year, the results were almost similar to that we had in ISAT. 33.7% in clipping and 23.2% in coiling. They had a poor outcome. This was the trial, 233 and 238, and this is the one which I'm mentioning. From coil, they were transferred to clip. And they published the results at 3 years, 6 years, and 10 years. In 3 years, 35.8% versus 30%. That means at 1 year, the result what they saw at 1 year has the gap between the coiling and the clipping has decreased. Now it's 35.8 and 30%. So clinically, it might be significant, but statistically, it was not significant. The significance at 1 year did not be maintained. It was not maintained. Rather, if you see the degree of obliteration, recurrence, and rate of retreatment was significantly better. Similarly, in the 6 years also, you see it was there was no difference in the two treatment groups, but overall retreatment rates was 4.6% for clipping and openly 16.4% for coiling. So this was the result of 10 years. Aneurysm retreatment 20% for coiling and only 1% for clipping. We should not forget 20% for coiling and 1% for clipping. Similarly, obliteration rate 22%, only 22% for coiling and 93% for clipping. And death and dependent at 10 years, 53.4% for coiling and 51.1% for clipping. So the statistical significance was not there for death and dependency, but retreatment and obliteration was statistically significant and better in coiling, better in clipping rather than in coiling. But there are also lots of criticism because it's a single center underpowered study. So when they started the trial, they did it with intent to treat, and all the different types of aneurysms were included. But the recent 10-year study, which I just now discussed, they did a post hoc analysis for the saccular aneurysms only because they wanted to compare it with the saccular aneurysms of the ISAT. So, but this was a post hoc analysis, and which is not considered a very strong statistical tool. At the end of 10-year period, 50 of the 54% of the clipped aneurysms had a complete occlusion status, and only 5% of the coil. But what we should not forget is they have seen only 54 patients and 23 patients. So we can't say whether the other patients in whom the angiography was not done, whether they had a better coiling and a better obliteration rate or not. So this is one of the major critical point. And the other point is the aneurysm coiling has evolved within the 5 to 6 years. It has evolved so much. However, only detachable coils were used in the isolation without the more sophisticated endovascular occlusion strategies. So this might not. There are other studies also which wanted to see the impact of coiling versus clipping, and this was in Canada, Ontario, by Dr. Abhay Kulkarni and O'Kelly. But it was a retrospective cohort study. However, it showed the endovascular coiling was associated with a significantly increased hazard of death or SAS readmission, as high as 25%. But this study should not be taken as a face value because provincial administrative data was taken, and it was a retrospective cohort study. So they did it from 95 to 2004. Coiling was associated with a significantly increased rate of mortality. 778 were treated by endovascular and 235. There was another study, it was a CARAT study. This wanted to see at other aspects like the predictors of rehemorrhage after treatment of ruptured intracranial aneurysms. So after you treat an aneurysm with coiling or clipping, you'd like to see whether the chances of rehemorrhage is high in coiling or clipping. So what they found was the degree of aneurysm occlusion after treatment was strongly associated with re-rupture. So less the occlusion, more the chances of re-rupture, which we already know. But what they showed was even if there was complete occlusion, the chances, the 1.1% chance that it might re-rupture. And if it is 70%, it's 17.6% chance of re-rupture. So if an aneurysm is not completely occluded, the chances of re-rupture is high. This should be taken in consideration when we send our patients for coiling. Overall re-rupture in coil embolization was 3.4% and surgical clipping was 1.3%. But there was no difference after the adjustment was done. Now, there is one ongoing study. That's a ISAT-2. In ISAT-2, because ISAT-1 had a controversy because they are selected saccular anterior circulation aneurysm. So this is a study in which they wanted to study. They are still going on. The study is still going on. I think the results will be out by 2023. Non-ISET group of population will be is being studied, and we'll know the results when it is published. Now coming to the concept of hybrid neurosurgeon. So a hybrid neurosurgeon for me is one who does exclusively vascular neurosurgery and is being trained in endovascular neurosurgery. So there are different topics that are coming, like it's panacea to prevent coiling versus clipping, whether it's a panacea or not. Whether it's the need of the hour. And there was a study done, published in JNS, the impact of hybrid neurosurgeons on the outcome of endovascular coiling for unruptured cerebral aneurysm. This was for unruptured cerebral aneurysms. But when they studied, they found that if it's done, the coiling, endovascular coiling is done only by the interventional neuroradiologist compared to if it is done by a hybrid neurosurgeon, the outcomes were almost similar. So this was, this I took from a Japanese paper, and in Japan you have very sub-specialization. So what they say is if a vascular surgeon gets trained in endovascular, then he'll become a hybrid neurosurgeon. A vascular or a skull-based surgeon gets trained in endovascular surgery, will become a hybrid neurosurgeon. So we already, many people may not be knowing, but we already have 4 vascular hybrid neurosurgeons in our country: Dr. Pravesh Raj Bhandari, Dr. Karuna Tamraka, Dr. Manoj Bohra, Dr. Robin Bhattrai. So we can take help from them whenever we are managing patients with subarachnoid hemorrhage or unruptured intracranial aneurysms as well. So what are the issues with coiling? Because most of us here are non-hybrid neurosurgeons. We are neurosurgeons. So we might have to know what are the issues with coiling, because we might have to send many patients to coiling by hybrid surgeons or for the neurointerventionist. So the issues are obliteration rate. The obliteration rate in long term is less. And this was a paper by the Medanta group, Dr. Vipul Gupta, when he was in Medanta, they had published this. And what they have shown is 100% occlusion in 78%. That's a very high number. And less than 70% occlusion in 2 patients. So if we see 18 plus 2, 20, around 22% of the patients, you might not be able to get complete occlusion. And this is for coiling. Whenever we clip the patients, all the vascular neurosurgeons must be, they are very fed up if they are not able to clip the neck properly. So they take a lot of time to clip the neck to attain 100% occlusion. So if we see 77% is a very good number for 77% clip occlusion is good for coiling, then I think we should not try very hard to achieve excellent results and putting the patient at risk. So the infrastructure, because many center infrastructure is a totally different, you need a biplanar to do it, and it costs money. The cost analysis for the patients, and intra-procedural aneurysm rupture. This is one thing which is missing in many parts of the discussion. Because if you see intra-procedural aneurysm rupture occurs more in clipping, as high as 19% as per some papers. It's low in endovascular coiling, but it's still there, around 5%. If I put a number, it's around 5% of the patients, they have an intraprocedural rupture. And if there is an intraprocedural rupture, the chances of mortality is very high. Some papers have reported as high as 40%. It might be a minor or a major rupture, but they have quoted as high as 40% chances of mortality. So intraprocedural aneurysm rupture is also there. We have to consider coiling. So why the coiling preference? Non-invasive bias, because this was what I asked my wife. My wife is not a medical person. I asked her if someone has an aneurysm and the coiling is this and clipping is this, and she said anyone would go for coiling because it's non-invasive. You don't have to open a skull. So that's the non-invasive bias. No surgery-related complications, which most of our patients fear. It is considered safe for medically compromised person, which doesn't hold true. Phobia for surgery. However, we are already treating so many patients with complex lesions. And non-uniform skill training. So non-uniform skill training in neurosurgery, especially aneurysm clipping. Market driven is one thing which we can keep on discussing. So what's the pragmatic approach? For me, if it's a wide aneurysm, MC aneurysm, associated large hematoma, inadequate vascular access, intraluminal thrombus, contrast issues, renal dysfunction, complete occlusion unlikely, and in a younger patients, I would prefer the patients for clipping. And if it's a posterior circulation, if there is vasospasm already there, difficult surgical access, and multiple aneurysms in bilateral cerebral hemispheres, and high-grade assays, I would want the patient to go for coiling. There might be varied opinions. And this was one from our own colleague Rajan Sharma with Yeko Kada. He had published a paper, Interdisciplinary Neurology. It's a good paper. They have discussed various approaches, whether to select a clipping or coiling. So I would like to conclude by saying that sole treatment option is increasingly artificial. Clipping or coiling is completely artificial. We have to discuss so that no aneurysm should be considered for treatment without bringing to bear all the tools that are available. It's always good to have both the tools. If someone wants to be a vascular neurosurgeon, it's better to have an endovascular colleague with you rather than thinking that the endovascular colleague will take away all my aneurysms for coiling, so I will be left with less amount of patients. As clinicians, our primary interest should be patient outcome. The onus of training younger colleagues for handling aneurysm lies on the senior. This is one point I would like to highlight. So we would want more and more of our younger colleagues to be trained in either vascular neurosurgery, clipping or coiling, or both. And skilled vascular neurosurgeons and skilled endovascular specialists is our need. So my question was, coil or clip, are we still confused? And the answer is we are still confused. So with this, I would like to, rather than questions, I would like to go for discussions. And before going that, I would like to make one announcement. Nepal Epilepsy Society invites you for webinar on Thursday, 29th Shravan. That good topics, withdrawal of anti-epileptic drugs and management of post-stroke epilepsy. So over to Dr. Mohan now.
Thank you, Dr. Gopal. Very nice and very balanced presentation. And I think before I say anything, the floor should be open to discussion, comment. Or Amit, do you want to post the multiple choice question for points?
Yes, sir. So let me first of all congratulate Dr. Gopal and request him to stop sharing so that I can present the Mentimeter.com evaluation post-test. Dr. Gopal, please stop sharing.
Yes.
Thank you. So now I will be just putting up the slides for the post-test. So I believe this particular slide is open, is seen to everybody. So anybody can scan the QR code and it will direct you to the website, or you can just press in www.menti.com and then enter the code. So let me start the post test now. So you can take any name. So here comes the first question. Safari score includes all of the following except. So just touch the best answer which you think of. That's true. So the most of the respondents have actually picked the right answer, that is the gender. It is not included in the Safari score. Which of the following antihypertensive is not preferred in a patient with acute subarachnoid hemorrhage? The options are labetalol, nicardipine, enalapril, or nitroglycerin. So again, the democratic vote is for nitroglycerin, and that's the right answer. Now we move to the third question. Admitting order for acute subarachnoid hemorrhage includes all of the following except. So which one of these options we do not mark or rather write for as an admitting order for acute subarachnoid hemorrhage? Okay, so most of us is right. And this is the last question for the post test, which will then be followed by the feedback. Sensitivity of CT scan for diagnosis of acute subarachnoid hemorrhage in a patient with thunderclap headache of less than 6 hour duration. How much is the sensitivity? You have to pick up the best option. 85 to 90%, 90 to 95%, more than 95%, or 70 to 75%. The right answer is more than 95%. In fact, I remember Binod has written in his slide as approximately reaching 100% in one of the series. Yeah. So this is for the feedback. You can opt for as many options as you feel it's right for you. What do you think the present webinar has helped you with? The knowledge, knowing of the controversies in literature, clinical management, decision making. Okay, so all of us feel that the presenters have done very good job in presenting equally important things in this presentation. Now this is the last feedback question. Do you recommend this presentation to your peers? The options are absolutely no, maybe no, neutral, maybe yes, or absolutely yes. You can touch it again if in case you have submitted that answer wrongly. So thank you for your participation, and let me invite you to the next week's webinar, and this will be on overview and management of neuropathic pain, 15th of August, same time. So thank you once again, and over to you, Professor Bhumi.
Okay, thank you, Dr. Amit, for conducting this quiz. Very entertaining also, and recapitulated knowledge. So actually, both the presenters are from my same institute. So whatever I say will be was already reflected in those papers. So I invite comments from other colleagues, senior, junior, both. So anything, what are the groups? Pavan sir, your opinion?
Thank you, Manan.
Yeah.
Hello, am I audible?
Yes. Yes, sir.
Yes. Thank you, Mohan, for asking me. And first of all, I would like to say thanks to both the presenter. They have done a very hard work and presented it very nicely and have covered more or less whatever we teach to our students. And this controversy of the coiling and the clipping is since last many years rather when it has just started. Until now, it is not settled. And how much time it will take is very difficult to say. As Gopal himself said, he is still confused. Likewise, I am still confused. But I have one plan in my brain because biasness for the doctors and the civilians. There are two groups of the people. So civilians go for the clipping, go for the coiling rather than the clipping. There are biasness for the various factors. So if ruptured aneurysms among the doctors, if there are few centers who are selected that ruptured aneurysm among the doctors who knows the facts very well, and now if their choice comes, so that may settle the confusion. Of course, that may be scientific or not, I don't know. Because still, in the last presentation in the hotel Hyatt, if you remember, Mohan presented very nice, but still, the very much, I mean, the neurosurgeons, very much neurovascular surgeons from a very centers where the maximum cases are coming to them, they were telling that 80% of the patient choice is for the coiling rather than the clip. So it is the general public sentiments. So if the doctors are involved and doctors are themselves the sufferers, what could be the result? That is one. And among 90 of us, because we are at present 90 in the nation, if we develop a sort of the queries and the questionnaire among the 90s, what is the result? Because other factors are certainly having a upper hand over the in the issues rather than the statistics and the surgery. So that is what I'm still confused. But certainly, if you ask my opinion, if certainly because of my age and many problems, maybe if I have this problem, I shall go for the coiling rather than the clipping. Thank you.
Yes. Patient's wish is the ultimate thing. Now, patient has the right to his or her body. So we have to present the fact to the patient, and it is the patient who makes the ultimate decision, sir. So well agreed, well made remarks. So Manoj, you want to say something?
Yeah. Yes, sir. First of all, I would like to thank both the speakers. And Dr. Gopal, it was a very balanced presentation, not biased to any of the treatment modality. And actually, we cannot generalize, I guess, like generalize and say coiling is better than clipping or clipping is better than coiling. I think it is like it is individualized to every case, as already discussed, and we have to for that we need hybrid neurosurgeons, because they will not be biased towards any of the treatment modality. Because if one is performing one treatment like solely, there is tendency to be biased towards that treatment, obviously. So I think if we have some colleagues in our team who can do endovascular as well, or neurovascular and endovascular, so I think that will be great to have discussion case by case. Like, we cannot generalize and say that coiling is better. I love clipping as much as I love coiling, so both are like excellent techniques. So the indications have already been discussed, and Dr. Pravesh has also mentioned in a comment that wide-necked aneurysm and having a big hematoma and bleed obviously will be better dealt by clipping. And as some data were mentioned, like it was old paper, that coiling has very high incomplete obliteration rate. But because of the advancement of technology, we are having new and new devices every year. So because of those devices, the obliteration rate, this problem has been well dealt recently. But in case of ruptured aneurysm, still there is problem, because in unruptured we can use stent assisted coiling, so which has a very high packing rate, because if we use the stent, we are not scared that the coil will fall down to the parent artery and cause other thromboembolic complications. So in unruptured aneurysm, we can use stent assisted coiling, so that will have very high occlusion rate and decrease the risk of re-rupture. But in case of ruptured aneurysm, although recently worldwide they are using stent and flow diverter even in ruptured cases, but we need to use double antiplatelets if we use stent or flow diverter in ruptured cases, so which may again increase the risk of hemorrhage if we use double antiplatelets. So so far what we are practicing is if it is like saccular very good neck, just simple coiling, we don't use any adjunctive technique in the parent artery, just simple coiling. But if it is a wide neck, means slightly difficult for simple coiling, we use balloon assisted coiling. So balloon acts as a protection for coil herniation into the parent artery. So these techniques are used, but if we have a very wide neck aneurysm, sometimes balloon assisted is not enough. So in those cases, obviously clipping will be favorable in such cases. So as already discussed, I think every case should be individualized and discussed by both views, like which is better for which patient, rather than just debating coiling is better or clipping is better. So I think every patient is individual and every case is different from each other. So I think we should focus on like all the aspects, like morphology of the aneurysm, size and parent artery, and then decide which treatment is favorable.
Okay, thank you.
Can
Dr.
I-
Ponta here. Dr. Ponta,
Can I-
you
Sir,
want to
can I add
respond?
something?
Gopal, you want to respond?
No, I wanted our international friend also to have his view. Dr. Haradan Devnath from Dhaka is there. If you-
Okay. Please introduce yourself and
Dr. Devnath.
please unmute yourself. Please unmute yourself. Please unmute Dr. Devnath.
Can you hear me?
Yeah,
Yes. Yes.
Thank you for giving me the chance for introducing myself. I'm working as a professor of neurosurgery at Mohammed Technology Medical University, Dhaka. There are many students who pass from our university, like Sudan, Tenju, and Pawan, and many other students. This is an excellent presentation by Gopal Sadan and another other presenters. There is an excellent debating between the coiling and clipping. I like both. Though I don't do the endovascular coiling, but I used to do the DSA in our cardiac sector, and I also used to do the cranial microsurgical clipping. And I think so that indication, according to the indication and patient needs, we can decide both, either clipping or coiling. They should, every neurosurgeon should know both of them. And one mentioned that everybody should know the both of the option and patient wish and also indication of surgery. Usually posterior is difficult to do the microsurgical dipping, and posterior is safe for the coiling. Anterior circulation can be done by either dipping and coiling. And thank you for giving me the chance. Here is the Professor Kutu Sharma. He has come to Dhaka different time, and he joined our conference. Thank you for giving me the chance to the Society of Nepalese Neurosurgeons. Thank you.
Thank you. Thank you, sir. Thank you for your comment. One thing I like to say here is, now if you want to do endovascular, you have to train yourself to be a pure endovascular. If you want to be a microsurgeon, microsurgical, then you have to train yourself on that. So-called hybrid, I am not quite sure. The technological advancement and the techniques you have to learn every day has evolved so rapidly that you cannot keep pace with the endovascular technology and keep pace with the microsurgical clipping. So you can be a hybrid to begin with, but then you have to choose a path where you want to go, because you have to catch up with the literature, technological learning. So that's the one thing I like to add to the both speakers' presentation. Another is clipping up a previous. Hello.
Yes.
And the clipping of a previously coiled aneurysm is very difficult with a very high morbidity and mortality. That part also should be taken into consideration. And while we had a hot debate in Hyatt that whether cost should come into your decision making or not. Atul Goyal was very aggressive, saying that money should never come in your way. But we have to be practical also. That monetary issue has also to be taken into consideration, because if it is a giant aneurysm, big aneurysm, and can be equally clip and coil or clip with equal morbidity and morbidity, then the money comes into as a factor. But if some aneurysm is suitable for coiling rather than clipping, then money should not come as a factor. That's my another opinion. Praveen, you wanted to say something, please.
Actually, I was writing rather than trying to speak out something, because probably many people are interested or would like to speak something in this.
No, we can go up to 7 o'clock, no problem. Everybody will have the opportunity to say something.
Even then, thank you very much, the speakers and moderators for the excellent presentation and excellent overall conduction of the webinar. Regarding this clipping and coiling, I have slightly different opinion based on the international scenario at this moment as compared to the scenario maybe 1 or 2 decades back. So now I think time has come that we should say coiling and clipping rather than coiling or clipping. Because the scenario is many, both the surgeons, interventionists and these open surgeons, they have started working together rather than criticizing each other. Because it was around 1 decade back or 2 decades back when the coiling started coming up so rapidly, and they started challenging the microvascular surgeons regarding they are now better. But now time has come, both of them have realized their limitations, realized both the plus and minus of these techniques, and they have now started coming up together and working as a hybrid surgeon, or maybe even if the interventionist is a radiologist, then he has started working together with the neurosurgeon, and neurosurgeon working together with radiologist interventionist. So now time has come that we should say clipping and coiling rather than clipping or coiling, number one. So personally, I don't have any confusion. I don't have any doubt. As many people have said here that we should work together. This is a theme. We shouldn't have any confusion. We should discuss openly and come to the final conclusion depending upon the wish of the patient as well, not only on the basis of our own technology, number one. Number two, clipping definitely has, coiling definitely has some benefit. For example, follow-up. Follow-up is much easier in case of coiling. Well, doing angiography is almost equal in the both, whether it is clipping or coiling. But in case of coiling, when we do follow-up and when we see in the angiography, if we see some sort of coil compaction, if we see there is some open space, free space inside the aneurysm because of coil compaction, then immediately we can go for the recoiling, which is much easier than coiling for the first time, which is much easier than going and clipping again. So follow-up angiography, follow-up coiling is much more easier in case of coiling technology. So definitely that is one of the benefit of the coiling as compared to clipping. And the final point I would like to mention is regarding aneurysm in COVID. This is a big topic these days. So far as my knowledge is concerned, there is no study or specific reports on the basis of whether aneurysm is really closely associated with COVID or not. But the cases have been reported. And it has been postulated that definitely the basic pathophysiology of COVID has led to the development of newer aneurysms, or has led to the scenario where the aneurysm rupture easily, mainly because of the two facts. One is direct involvement of the blood vessels because of the viral infection, leading to vasculitis, leading to easy rupture of the aneurysm, or even rupture of normal blood vessel, number one. Number two, because of the ongoing immunopathology, because of ongoing hyper-response syndrome of COVID-19, there is easy development of the aneurysm because of the involvement of blood vessels. So it has been postulated that the possibility of having newer aneurysms or the possibility of having rupture of the already existing aneurysm is higher in the COVID era. However, it has not been studied yet, and a few cases have been reported now, but definitely it seems the postulation is true. I think that this is all about this today's topic.
Great. All right. Dr. Rajiv Jha, somewhere here. Dr. Rajiv not there.
Dr. Pravesh also wants to say something. Pravesh, our hybrid.
Pravesh, yeah.
Our
Thank you,
first
sir.
hybrid. Our first hybrid.
No, sir, it's okay. Gopal, nice presentation. Vinod, nice presentation. And I was very astonished how Gopal put everything so gently and diplomatically. The wrestler was the big, nice image that you put. My thought regarding coiling and clipping is simple aneurysm, incidental, very good for coiling. If there's acute bleed, then clipping is the best. But what I see is that the neurovascular training should be more good in bypass, vascular bypass in giant aneurysm, where flow diverter is taking its place. But in Nepal, when we see giant aneurysm and we tell them that flow diverter is good, people cannot afford the flow diverter because it's very costly. So then the option of bypass and trapping will come in Nepal. So we have to improvise our skills on bypass so that still Nepal will have more cases where neurosurgeons can perform this, because flow diverter is very costly. And whenever there is a wide neck aneurysm, when we want to put a stent or when we want to use balloon, complication rate will increase. Then I think that even the cost factor is going to increase. Then I think that no, in this type of cases, clipping would be much better, because the wide neck can be clipped by a single clip, which doesn't even cost 15,000. Whereas when you put a stent on that, it will cost in lakhs, 4 or 5 lakhs. So cost is the primary issue in Nepal, where neurointervention will not flourish as it should have flourished in the Western world. So neurovascular surgeons should be proud and improvise our skills in neurovascular clipping and bypass, so that still we will not be scared from the neurointerventionist. And Mohan sir, residents should go to the cath lab and perform DSA. And when they perform DSA, their eyes would open, vascular from downwards and vascular from above. So when they see from down, they will see something else. Neurovascular anatomy will change, and their thinking of hybrid neurosurgeon would come up, sir. So we can't just say that neurosurgeon, neurointerventionist, and neurohybrid. Neurohybrid should come up, like Manoj was also saying. Thank you, sir.
Okay. All right. Amit, you want to say, Dr. Amit Thappa? You do a lot of vascular.
Thank you, sir. And I've been listening to all the comments. And first of all, let me again congratulate the presenters for having presented a very, very elaborative and well researched topics. There are a lot of confusion in this acute subarachnoid hemorrhage. I'm not talking just of coiling, as what Gopal just said. There are many other issues which still remain unanswered, and which Dr. Vinod has rightly put up in his slides. I will not be repeating those. But then, just to share my experience with the hybrid neurosurgeons, like most of my friends have become hybrid neurosurgeons, and when I inquired with them like about their amount of practice they are into the endovascular, or they are doing open clipping, so I see a very, very clear divide even in the hybrid neurosurgeons. There will be a few group of the hybrid neurosurgeons who are even now doing 90% of their surgeries openly as compared to the endovascular. But then there are other hybrid group of hybrid neurosurgeons who are actually giving 90% endovascular, only giving 10% craniotomy. So I don't know the reason why they actually there's such a divide amongst them. But then it seems that everybody has a personal biasness, and the personal biasness actually starts with the results they get with their practice. So I conjure with Professor Mohan when he says that whatever you do, you have to do in a full heart. So if you're doing an open surgery, then be as good as what Dr. Pravesh has been talking about, even in making a bypass, so that you excel in that. However, if you're doing an endovascular stuff, then you do in such a manner that any complicated aneurysms also you can do away with it very skillfully and with the best outcome. The problem is that when we create a lot of options for us, if in case there's no endovascular, we can go for open. It is just like asking an endoscopic surgeon whether you want to do a transnasal or transcranial. So he will actually evaluate. He will see, okay, I'm good in open surgery, so I will try to do an open method whenever there is a complication. But then that's not to be done. If you ask very talented endovascopic surgeons, they will always have some method, devices to deal with complication, even with the endoscopic approaches. So even though the trend is towards the hybrid neurosurgeon, we should try to excel in one of these so that we can actually do away with these lot of complicated cases. Now, I will just ask a few questions to the presenters, and anybody can answer. What would be your choice if in case you see atherosclerotic plaque or a calcification in an aneurysm which has ruptured? That's number one question. And number two question is that if you see a blister aneurysm, what will you like to do for a patient who has an acute thoracic hemorrhage?
Yes. Who should respond? Gopal, you want to respond?
This is for everyone, sir.
Okay. That's what I'm. Who should respond? Should I or anybody?
I think we can start with Professor Mon.
Yeah. His first question is, if there is atherosclerosis, how do you approach aneurysm?
Yes. If in case there's a calcified or a atherosclerotic plaque, which is seen on an angio.
Yes. Yeah. If the vessel is atherosclerotic, I'll be very reluctant to use temporary clip. Temporary clip can cause dislodgement of the plaque and cause distal stroke. So even after an uncomplicated clipping, if the patient develops stroke, this is usually the case. So we should be very careful in not using temporary clip. There can be situations when you are forced to, but in the majority of the cases, we should not be using temporary clip as far as possible. That's number one. Number two, blister aneurysm somehow was not touched in the presentation, Gopal. Very nice question. Blister aneurysm is one aneurysm which is not suitable for coiling because it is in the non-branching side. So it has to be clipped, and the clipping of a blister aneurysm takes a lot of experience. They are so fragile, they can rupture, and clipping is very difficult technically. I remember Dr. Kinuchi presenting on how to do blister aneurysm clipping, and you have to use wrap technique and wisp of cotton and then miniature clip, lot of things. But blister aneurysm is something which you should not be doing in your first 10 cases. I'm saying this to the younger neurosurgeon. They are technically very demanding, though they can be done. And most of the time they are in the internal carotid artery area, and you should be able to do it with relatively good experience. Anybody wants to add more on Amit's question?
Sir, recently, even like very experienced endovascular surgeons are doing blister aneurysm by endovascular means, mainly using flow diverter. So reconstructing the parent artery, and then the flow doesn't go to the aneurysm, and so it gets treated in few months. But as I said in my previous comment, that the problem is if it is ruptured. So if we use a flow diverter, we need to give double antiplatelets. So, but still it is being practiced now because as you said, like if an endovascular surgeon wants to do, so he should be able to do every complex case as well. So even like loading dose of aspirin is being given just before starting, and then continuing with antiplatelets post procedure. But so far, as I go to the conferences and I always ask this question, so they say they don't have much hemorrhagic complications with antiplatelets. So flow diverter can be a very good option for blister aneurysm.
Blister.
Yeah.
Dr. Yam is there in the audience. Dr. Yam Roka, where is he? Dr. Yam, you should make some comment. Maybe we have gone past our allotted time, so majority have left maybe. Huh? So Amit, so time to wind up things then. Dr. Amit Thapa.
Yes, sir.
Dr. Krishna here. Dr. Krishna, President.
Dr. Dr. Krishna was having some problem with his internet. So he sent me a message that if I am not around, please share this message. So he has a
Okay.
problem connecting.
Okay, then I think it's 6:30 already. We, as expected, this topic always generates a lot of interest in the discussion, and this took 1 hour and a half, and it was a very nice presentation. I congratulate both the speakers for summing up the things. This is a huge topic, takes months to digest, but they have done the, they have done the reasonable work and present to us all the recent advances. And I thank Dr. Amit Thapa especially for organizing such beautiful, webinars series. Today is 19th, I believe.
This is yeah.
Yeah, 19th, and I thank the Nation Educational Committee. I think we should have an educational committee as a separate committee from now onward, just like WFNS and ACNS. For conducting and for running this show. Thank you very much, everybody.
So thank you, everyone.
Thank you. Thank you.
Thank you.
Thank you.
Thank you so much.
Thank you.